The last therapy that I'm going to talk about is dialectic behavioral therapy. And this is, again, different from those that I've presented. It's really focusing on that two opposites can exist at one time. And neither one is right or wrong, but they just coexist. And DBT was actually developed by Marsha Linehan, who's at the University of Washington. She's a psychologist, and she originally developed it for adults who had a lot of suicidal behavior, a long history of suicidal behavior, as well as self-harm, so NSSI. And then eventually it was applied to patients that met criteria for borderline personality disorder, and later to youth and adolescents. So DBT is based off of the stress diathesis model that Dr. Mathias had presented, which basically states, again, that there can be multiple factors associated with a suicide attempt. And again, these can be biological, social, etc. And DBT is based on dialectics, which is the coexistence of opposites. Basically, that a patient needs to accept themselves for who they are, but at the same time needs to change so that they can have a better life for themselves. That the destructive behavior that they are doing is not healthy. So you can accept it, but you need to change it. And it's really a balance of empathy and acceptance. So it's feeling okay that you can feel for the patient and accept the patient for who they are, but also encouraging that they need to change their behavior, their feelings, and their emotions and their thoughts that are associated with this type of behavior. So there are a couple of assumptions that Linehan proposed about people who participate in DBT. The first assumption is that patients are doing the best that they can, given their certain life situation, and that the destructive behavior is understandable. So given what they have going on, I mean, some of the families that come in, I'm surprised that they can even make it to our lab because they have so much going on. Whether it be, that adolescent has experiences with sexual abuse or, has a child or what have you. There's so much going on. And Linehan would say that it is understandable that they are actually hurting themselves. This destructive behavior is acceptable. But we have to change that in order for them to get better. And they want to change that, and that's why they're there. Folks that enroll in DBT are very serious about changing their behavior, and they're overwhelmed whenever they've tried to change it themselves. So they feel that they try and they just can't get it together. And they do have a strong commitment to change, it's just they don't know how to. And in order to create these new behaviors that can lead to positive outcomes, it has to be not only just when you're dealing with one specific situation, it has to be when you're dealing with life itself. So everyday life events, you have to be able to deal with those, and you'll learn these specific behaviors to implement when dealing with those life events. So there are a couple of skills that are taught in DBT. The first one that Linehan believes is really key in handling one's emotions is mindfulness. And mindfulness is basically taking every moment you have and observing everything that's happening within you as well as around you. So really taking in the moment, not thinking about the past, not thinking about the future, thinking about right now. And she believes that this should be done in good times and in bad times, not one or the other. The next skill that is taught is interpersonal effectiveness. And in this skill, the adolescent will learn how to effectively negotiate for what they want, and also be able to say no, because sometimes that's a problem, and also learn how to deal with interpersonal conflict. Sometimes it's not okay to just walk away, so they have to understand that. The next skill that's learned is emotion regulation, And this is basically focusing on labeling emotions and identifying that there are certain obstacles in changing one's emotions. Also, increasing your mindfulness about the emotions that you're experiencing right now or in that stressful situation. And then distress tolerance, which Dr. Mathias talked to on a little bit, is learning how to deal with a bad experience and not make it any worse. So understanding that, yes, this is distress. Yes, I'm stressed out by it. Accepting that you're stressed out by it. And then making some meaning about that. And then moving on and tolerating that you're in that situation. And trying not to do the behaviors that you've done in the past to make it worse. And then finally, self-management is the other skill that's taught. And this really relies upon self-acceptance. It's really about understanding one's vulnerabilities and also your strengths, and understanding that you can learn and practice skills that can sustain relationships that are healthy, and also build on your sense of belongingness. So those are the main skills that are taught in DBT. So what is involved with DBT? There's 4 major components. The first one is weekly individual psychotherapy with the adolescent. And this is done once a week. The patient and the therapist meet together. And during the therapy, the first priority is to address any self-injurious behavior or suicidal behaviors that have occurred. And then the therapist and the patient try to understand what contributes to those problems and how they interfere with them changing. So together they build these new effective alternatives that they can use and that can be applied in stressful situations. The second component is the skills training classes, and this is basically where they learn specific skills that they can apply in different ways of managing their emotional distress. And then the third component, which is very different from others that I've seen, is this consultation for meetings for the actual therapists themselves. So therapists that conduct DBT actually meet together and do consultation with themselves to kind of figure out not only ways of addressing the specific case that they have, but also to try to provide effective and compassionate treatment for their patients. So they give each other ideas of how to be more compassionate or how to be more effective with a specific case. And then finally, the between session coaching, which is done by the therapist, and it gives the patient the opportunity for a real life coaching experience. And this is where the adolescent is using the skills that are being learned in the sessions, but in real life situations. So the coaching can actually occur via email or telephone, and the primary focus is to decrease crisis. So this is after hours. Basically, the adolescent can contact the therapist, and that is something that is agreed upon, like when it's okay, when it's not okay, at the very forefront of therapy. But basically, this type of therapy is very intensive. It goes on past when that session is over. So those are the things that are involved, those 4 components. And then there are also stages to DBT as well. So there are 4 stages that are distinct. And during the first stage, the focus is mainly on decreasing life-threatening behaviors. So what you want to do is really make sure that this kid is safe. And that's really what's the main focus of stage 1, is taking a child from behavioral discontrol to behavioral control. You're trying to get their behavior under control. And you're trying to reduce the hospitalizations that they're experiencing and also decrease behaviors that are interfering with the quality of life, as well as increasing some coping mechanisms and also increasing ways to deal with their actual emotions and dealing with life itself. It's really about making sure that these kids have a normal life expectancy, and that's quoted from Linehan specifically. And then during stage 2, you are actually trying to deal with traumatic stress, so decreasing traumatic stress. And you can only move to stage 2 once the adolescent has their behavior under control. You cannot advance until you have that completed. And basically during this stage, adolescents or patients are thought to be in a state of quiet desperation, and you want to move them from that state onto full emotional experiencing. And during this stage, you can actually treat post-traumatic stress and actually explore the past traumas that they have experienced, as well as the maladaptive thoughts and beliefs that they have about those experiences. So the primary goal is to basically take traumatic stress and remember the traumatic stress, accept the facts about the traumatic stress, and then also have reduced the stigmatism that's been assigned to that traumatic event, as well as decrease any of the self-blame that these kids are experiencing. So again, in order to get to this stage, you do have to make sure that the adolescent is safe. You can't go there until you get that first stage completed. So the third phase is where the skill development occurs. So once we've dealt with post-traumatic stress and we've got the kids' behavior under control, now we can implement strategies that they can use in stressful life events. So we are going to come to an agreement of what skills are going to be used, and then also allow the adolescent to understand that life is happy and then there's unhappy moments. And they have to understand that it's okay and that's normal, and that there are skills to help you get through those unhappy moments. And it's really about learning skills about owning one's own behavior is one of the skills that they implement, trusting yourself, respecting yourself as an individual, as well as learning how to value yourself as a person. So it's not only these coping mechanisms that we're learning, but we're also learning that we are a person and we have value, as well as setting some individual goals for ourselves. So that's something else that they do during this stage, so that they can actually have some goals that they can implement or try to work towards in later phases of the treatment. And then finally, stage 4. In stage 4 in the DBT model, we're moving patients from a sense of incompleteness to a life that involves an ongoing capacity for freedom and joy. And during this stage, patients actually take the skills that they've learned in stage 3 and apply them to life experiences. And really, with those skills being applied, it's proposed that patients will learn that they actually have an overall sense of well-being, as well as a connection to the world that's around them. And also, they can connect and have healthy relationships with other people. So that is the main goals of the final stage of DBT. So, putting my research hat back on, I'm going to show you some research that's been done with adolescents using DBT specifically. So this was actually looking at 111 outpatients in Bronx, New York, and they had 82 of those adolescents in treatment as usual and 29 that participated in DBT. And they were exploring a couple of outcomes. Hospitalizations was one of the outcomes that they looked at, and then also attempts that occurred during treatment, as well as treatment completion. And those were the main focuses. But they also looked at, of course, suicidal ideation, depression as well. And what they found is that those that were in the treatment as usual group experienced more hospitalizations than those that were in the DBT group when they were going through therapy. They also found that those that were in the treatment as usual group didn't complete as all of the sessions that they were assigned compared to those that were in the DBT group. When it came to attempts, there wasn't a statistically significant outcome there, but as you can see, the proportion was larger in the treatment as usual group when compared to the DBT group. There were more attempts in the treatment as usual group. And also, there were decreases in suicidal ideation when you looked at baseline compared to the end of treatment. So there was a big difference there as well. And then another study that was done looked at 62 inpatients. And this study actually followed the adolescents over a year after they had completed the sessions of DBT. They were between 14 and 17 years old, and 26 of the patients had DBT, while 27 had treatment as usual. And they looked at a couple of things. They looked at depression, hopelessness, suicidal ideation, hospitalizations and ER visits for suicide attempts, and adherence to treatment. And what they found was that both groups actually improved when it came to depression, hopelessness, and suicidal ideation. But when you compared the two groups, they weren't different. So one group didn't do better than the other. But when you looked at total hospitalizations or ER visits, the treatment as usual group had more hospitalizations than the DBT group did. And also, there was a trend for DBT to actually be more adherent to the recommendations than compared to the treatment as usual group. So it does look like DBT does decrease the hospitalizations as well as increase treatment adherence. So now that I've kind of talked about treatment a little bit, and we've talked about theory, and we've talked a little bit about research, I think Dr. Matthias and I are very much into the research realm, but we know that all of these components work together to help us to do our jobs better. And the way that we think of it is that research, yes, is driven by theory, but also gives back to theory. And then also theory, which we have seen, is related to treatment, and then that also affects how theory and research work. So it's kind of like this puzzle that we're kind of putting together, and is always ever changing. And with that being said, I wanted to introduce the research study that we specifically work on, which we recruit kids from Clarity for. It's the South Texas Adolescent Transition Study, and it really looks at a number of the things that we've talked about today. It looks at suicide attempts and non-suicidal self-injury. It looks at psychiatric symptoms, treatment, serotonin function, and we're trying to understand the development of children as a whole by looking at different components. We are recruiting for this study. It's a 5-year study, and it includes children between 12 and 17 years old, and all of them have experienced a psychiatric hospitalization. And it could be any time in their entire lifetime. It doesn't have to be between 12 and 17 years old. If they experienced a hospitalization at 8, they are eligible for this study. And we actually see the parents and the adolescents every 6 months. They come in and they do a number of things. They complete an interview with us, as well as do some forms and computer tasks that look at decision-making skills. And each time they come, they're paid for their participation. And basically what we're hoping to find is ways that we can, again, going back to that previous picture, is that we can inform treatments, we can inform theory, and then keep this circle going, and hopefully get to a place where we can actually create therapies that can help these kids live healthy and happy lives. So if you are interested in taking part in the study, please feel free to call Paige, who is also one of our colleagues, and she'll give you more information about the study, as well as, if you are interested, give you some more questioning about eligibility.